Ireland, Dublin. So the first one is making things simple. And I'm delighted to invite 4 speakers for this symposium. We're going to run through each of the speakers' talk ahead of time. I'll introduce them just before their presentation. And then hopefully at the end, we'll have time for questions and answers and discussions. So I'm delighted to invite our first presenter, Una Lehman, who is our clinical nurse specialist here in Lucina CAM's Child and Adolescent Psychiatry Service in Dublin. And Una is specifically trained in the delivery of family-based treatment, which, as you know, is one of the evidence-based treatments for eating disorder. And this morning, this afternoon, your time, morning our time, Una is going to be presenting the components of SIMPLE, a pilot of standardized, integrated medical and psychiatry evaluation in eating disorders. Thank you, Una. A short video of Una's presentation is going to follow now.
My name is Una Lehman. I'm a community mental health nurse working in Lucina Clinic, a child and adolescent mental health service in Dublin, Ireland. Today I'm going to talk to you about SIMPLE, a standardized, inclusive medical and psychiatric evaluation of eating disorders. In order for me to explain SIMPLE, I'd like to first talk to you about who we are and what we do. We are a small team based in Dublin, Ireland. Our clinical lead, Professor Fiona McNicholas, and 6.5 clinicians of various clinical backgrounds, including nursing, psychology, and social work. Our clinicians are trained in FBT, family-based treatment for anorexia. We receive FBT-specific supervision with Dr. Aileen White. So as I mentioned, we're family-based treatment for anorexia. This is a manualized approach which was developed by James Locke and Daniel Lagrange. To give you a brief overview, FBT is a behavioral approach which works by empowering the parents and building back up their confidence in feeding their child. We remind the parents that anorexia affects the entire family and can make the parents struggle with their confidence and question their ability to support their child. The primary focus is on weight restoration rather than psychological change, while reminding the parents that the symptoms of anorexia, both physical and psychological, is weakened by weight restoration. For these children and adolescents, we have to remember that food is medicine. So where do we do it? As I mentioned, we're in Dublin, Ireland, specifically in Rathgar, and are very fortunate to work in a beautiful part of the world surrounded by lovely grounds. Lucina Clinic has 8 CAMS teams in total, all based in different locations. We cover Dublin South, Dublin West, and Wicklow. The total catchment population is 640,000. 145,000 of these are under the age of 18. This is 13% of Ireland's youth, which is a huge proportion. This catchment area is very culturally diverse. It's multi-ethnic and also includes both extremes of socioeconomic groups. When do we work? Unfortunately, due to limited resources, we can only run this clinic 1 day a week on a Monday. Ideally, we'd love to have a full-time team to allow us to take on all the young people referred to us and to branch out to other eating disorders. Since the COVID-19 pandemic, we've had to make adjustments and split our appointments into 2. Firstly, the young person is offered a nursing appointment in the morning, in order to medically monitor the young person, including their vital signs, urinalysis, and a weight check. Secondly, the family are then asked to attend a Zoom session later in the day with their designated FPT clinician. So why do we do it? Our FPT team was born out of the need to provide a better, safer, more efficient service to these very high-risk young people. International best practice guidelines recommend a family-based treatment approach for anorexia in children and young people as a first-line treatment. By developing this team, it allows us to accept referrals from each of our clinical teams, regardless of whether they have an FPT-trained clinician on their team or not, thus providing a more equal service across the board. There is increasing evidence that FPT is the gold standard treatment for anorexia nervosa, and also emerging evidence of its effectiveness in other eating disorders, such as ARFID and bulimia. So if we look at some of our more recent stats, in 2019, we started the year with 15 open cases with little to no waiting lists. Currently, we have 15 open cases and 18 on our waitlist. We can see by the chart we have had significantly more referrals in the past 18 months during the pandemic compared to pre-COVID rates. And at the same time, there are more young people suffering with anorexia that are being held by their teams and not referred in due to the extensive waitlist. So how do we work? We start on Mondays with nursing appointments for the young people, followed by clinicians' meetings to discuss case progression, as well as any new referrals that have come in during the week. This case discussion takes place with our clinical lead, Professor Fiona McNicholas, and then we have monthly FPT supervision as well as that. Ideally, we have 2 clinicians assigned to each case. However, due to increasing referrals and demands, we have worked many of these cases on our own over the last 18 months. The sessions normally begin as weekly and move to fortnightly along with the progression of recovery. So FPT has 3 phases, and I'll give you a little bit more detail about this and how we work. Phase 1 usually occurs between session 1 and 10. Its primary focus is on restoring healthy eating and refeeding the child. We empathize with the external effects anorexia has had on the parents, while also charging them with the task of refeeding their child. We must remember that the therapist is a consultant and not the expert. The therapist then talks openly and gravely about the long-term effects of anorexia and the physical complications that can occur. They encourage the parents to externalize anorexia. This is sometimes done by giving anorexia a name, and it allows the parents to separate the child from the illness. We have a family meal in session 2, again helping and encouraging the parents to support their child. The entire focus is on refeeding and improving the young person's health. We invite the full family to these sessions, including the siblings. The siblings have a specific role in the recovery of this young person. Their role is support. They're there for distraction, not for feeding. Continuing on to phase 2, the sessions are typically less frequent. And in this phase, there's ongoing medical monitoring, including weight, but there's a slow return and a gradual return of control back to the adolescent. So they may be able to eat certain meals unsupervised, or make their own snack, or make some decisions around their food. Then on to phase 3. Again, the sessions are moved further apart, Weight is continued to be monitored, and we focus on maintaining health. We also, in this phase, look at any other mental health needs that the child has and how we can support them there. So some conclusions that we have come to. What we've seen is that FBT is highly effective, particularly in cases where the eating disorder is of short duration. It is more effective to work with the family rather than psychodynamic individual therapy. Most young people respond very favorably to this. FBT is as effective when using the shorter or longer version. Early weight gain predicts recovery, and this is really important and something that we very much emphasize in the initial appointments. Adolescents with more severe symptoms seem to do better unless there's a comorbid presentation of ASD or OCD. The benefits of FBT are sustained for 4 to 5 years in the future. And overall, it is a shorter and cheaper treatment than hospital admissions. So just anorexia, that's a big question. Our clinic in Lucena was established for the treatment of anorexia. We certainly have had cases where during the course of the treatment, we have found evidence of ARFID, so avoidant restrictive food intake disorder, or other eating disorders. Some of these cases still progressed well in FBT and weight restored, at which point they were passed back to their CAMS team for further treatment and investigation. FBT is not a one-size-fits-all treatment. I don't know of any treatments that are. But for this reason, a thorough assessment, formulation, and diagnosis are very important in developing the most appropriate treatment plan. So if we have a look here, this is our current referral pathway. GPs refer to the CAMS teams. CAMS teams then decide to either accept this referral or deem the referral inappropriate and return the referral back to the GP. If that referral is accepted, the CAMS team do an initial assessment. If that patient is then seen to have an eating disorder and there's sufficient evidence for a diagnosis of anorexia nervosa, then a referral is made onto our FBT team. Again, this is screened and not all referrals are accepted. If the referral is accepted, it is then placed on our waitlist as urgent, semi-urgent, or routine. And if we look at the next slide, it'll show us a little bit more detail about what we do next. So the young person has been placed on the waitlist as urgent, semi-urgent, or routine. Once an FBT slot then becomes available, the young person is allocated an FBT therapist, and the family is given an appointment for a psychiatric simple assessment. A comprehensive assessment of the patient's eating disorder and developmental history is taken. Questionnaires are also given to both the parents and the young person, which inform our treatment and help us gain a further understanding of the young person and the family's needs. FBT treatment then begins initially weekly and then spread out along with progress. As previously said, nursing appointments are given to each patient in order to monitor the patient and continue to work in a safe manner. And then this is where the medical and dietetic piece of Simple comes in, where we refer patients to our Simple clinic, which takes place once a month for a pediatric and dietetic review. And just to say, the patients who are not accepted to our FBT waitlist is usually for a variety of reasons. They may have an eating disorder other than anorexia. There may be some family dynamics in the background that would not be suitable for an FBT approach. They may be medically unstable and need a medical admission into hospital. We need to consider all options available to us. So why SIMPLE? Again, SIMPLE stands for Standardized Inclusive Medical and Psychiatry Evaluation of Eating Disorders. Patients with anorexia nervosa are very high risk medically and in their mental health, and therefore our aim was to increase the level of safety of outpatient treatment and reduce the need for both inpatient medical and psychiatric admissions. All new clients accepted the FBT team get an initial psychiatric SIMPLE assessment in order to assess the suitability and safety of FBT. This assessment takes up to 2 hours, and a series of questionnaires are completed by the young person and their parents. Again, these questionnaires inform treatment and are seen as a baseline. Ideally, we would love to repeat these questionnaires again at the end of treatment to show progress as well as any other ongoing difficulties. From the open FBT list, cases identified as a concern are then forwarded to the SIMPLE clinic to be seen by a senior FBT-informed dietitian and a consultant pediatrician. This clinic takes place monthly. The purpose of this clinic is to increase safety and reduce admissions to hospital or inpatient units for young people who are medically unstable. So here we can see a breakdown of what each assessment involves: the psychiatric assessment, the medical assessment, and the dietetic assessment, as well as the questionnaires that are provided to both the young person and the adults. I'm not going to go into this in detail, as my colleagues will be speaking about their own specific roles later in the talk. So the logistics of SIMPLE. Psychiatric SIMPLE is offered to all patients commencing FBT. It's undertaken by Professor Fiona McNicholas, and a comprehensive history is obtained. These are some of the questionnaires that we would normally hand out. The medical and dietetic SIMPLE clinic takes place 1 morning per month. A maximum of 4 patients are seen in this clinic due to the lengthy appointments. So who's involved? We have Professor Fiona McNicholas, who is the consultant child and adolescent psychiatrist and clinical lead of our FBT team. Dr. Orla Walsh, consultant pediatrician from Temple Street, and Maria Keenan, senior dietitian currently working in Galway. Then there's Mark McKeown and myself as both the community mental health nurses. The day involves a comprehensive handover by the nursing staff. There's then a nursing physical assessment, including weight, height, blood pressure, heart rate, urinalysis, and a weight check. Young people and parents are then seen by the pediatrician for physical assessment and medical history. The young person and parents are also then seen by a senior dietitian for a full assessment. At the end, the staff meet again and arrange for feedback to be sent to the GP as well as the CAMS teams. The nursing staff provide continuation of care, being involved in both the FBT clinic and the SIMPLE clinic, and are able to provide feedback to the FBT clinicians at the next clinical day. We are constantly reviewing our clinic and looking for ways to improve our process and how we feed this information back to the clinicians, the GP, and the CAMS teams. These are some of the forms that we have developed. And believe me, these forms change monthly and are constantly adapting to our the needs of our clients and clinicians. So some of the practical issues and the dilemmas that we have come across. Triaging patients. This is something we talk about all of the time and get into healthy debates over. Triaging referrals is difficult to do. Do we base them on medical need or on the family suitability of FBT or the likelihood of a good outcome? We haven't quite come to a conclusion on this one, and again, the argument is ongoing. We only operate 1 day a week, so any questions or concerns that arise midweek end up going back to the CAMS team. And for this reason, we need to develop a positive relationship with the teams and develop a model of shared care. When we look at the 3 phases, can we do all 3 phases when we are only a 1 day a week team? Currently, we say no. We do phase 1 and 2, and then pass the cases back to the teams to complete phase 3 and look at any outstanding needs that the young person might have. The number of clinicians per case. Ideally, we'd love to have 2 clinicians per case. This allows for cross-cover if there's a clinician on annual leave or out sick, and it also allows for the training of more junior staff to sit in and support a more advanced clinician, but at the same time, learn from them. But with such a long waiting list, can we continue with this luxury? Or do we need to go with a 1 clinician treatment moving forward? We talk about business planning a lot. We talk about planning beyond anorexia. We know that there is so much more cases on our teams that could do with these models of care. And as I've said before, FBT has been proven to be effective in other eating disorders. But given that we're 1 day a week, this hinders this development. Our Simple Clinic and the value of Simple. We on the FBT team have found the Simple Clinic absolutely invaluable. It not only gives the family and the young person a clear understanding of their medical and dietary needs, it also supports the FBT clinicians and informs our sessions moving forward. At the moment, this is only offered to our open FBT cases, but given how successful we have found it, it would be fantastic to see it develop and roll out to other patients that can't unfortunately avail of FBT at the moment. So thank you for listening. I really hope that I've given you all something to think about, and I'm now going to pass you on to my colleague, Dr. Orr.
Una, thank you very much for the presentation. Just reminding our audience, by developing the Simple, what we were trying to do was, with the limited resources that we have in a busy child psychiatry clinic, how do we offer some expertise in eating disorder while at the same time making sure it's safe? And as Una hinted to there, given we know the comorbidity with medical problems in psychiatric patients, that actually it would be very helpful to roll the Simple model out into generic CAMS as well. And we're going to move on, if that's okay with the audience. We're going to move straight into the next video presentation by my colleague, Dr. Orla Walsh, who is a consultant pediatrician working in one of our pediatric hospitals. And Orla has extensive expertise and interest in adolescent health and eating disorders specifically. We will do questions at the end of the discussion, if that's okay. Thank you.
Today I'm here to talk about medical considerations in youth with eating disorders. My name is Dr. Orla Walsh, and I'm an adolescent medicine paediatrician in Children's Health Ireland at Temple Street in Dublin, Ireland. Eating disorders are complex illnesses with profound psychosocial and physical consequences including high rates of mortality. Despite growing recognition of their prevalence and severity, they remain underdiagnosed and undertreated. Pediatricians like myself play an important role in providing patients and their families with the care, resources, and guidance they need to reach and maintain recovery. In the starvation state, the body adapts by slowing metabolism and decreasing energy requirements. Eventually, the body is unable to maintain its regular functions and complications develop in nearly every system, with increasing risk of death. Most medical complications ultimately reverse with nutritional rehabilitation and weight restoration. However, some may be permanent. These include loss of dental enamel, structural brain changes, growth retardation, pubertal delay, and impaired acquisition of peak bone mass. Eating disorders are serious and potentially fatal disorders, with the highest mortality rates of any psychiatric illness. Adolescents with anorexia nervosa have a mortality rate that is 10 times that of their peers. Death is most commonly as a result of suicide or cardiovascular complications, including sudden death and congestive cardiac failure. Brain size and function is affected by starvation, chaotic eating, and weight loss. Psychological effects of this include mood swings, feeling sad, loss of interest, social withdrawal, irritability, difficulty concentrating, changes in sleep pattern, and memory issues. Cortical volumes may increase with weight restoration, but grey matter volume reduction may be irreversible in prolonged starvation. Clinically, this can result in psychomotor retardation and increased rigidity. Cardiovascular complications include structural and functional abnormalities. Most commonly seen include decreased cardiac mass, bradycardia, and hypotension, with resultant syncope. Arrhythmias can occur secondary to reduced myocardial contractility and prolonged QTC interval. Bradycardia, QTC prolongation, and electrolyte abnormalities are the most common reasons for hospitalization. Vomiting can also cause fluid and electrolyte abnormalities, which can contribute to these complications. Prolonged gastric emptying and delayed transit time occurs. Therefore, patients commonly have symptoms of bloating, constipation, early satiety, and generalized abdominal pain. Elevated transaminases can also occur. Dehydration can be seen secondary to restriction. However, if there is purging or water loading, other electrolyte abnormalities can also occur. The hormonal abnormalities associated with anorexia represent adaptive responses to chronic undernutrition. With nutrition rehabilitation, hormone secretion typically normalizes, but this may lag behind weight recovery. Euthyroid 6 syndrome is an adaptive response to starvation. In girls, they have amenorrhea from low FSH, LH, and estradiol. Boys have low testosterone. If you are prepubertal, you can have delayed puberty and growth retardation. And for those who are pubertal, the suppressed hypothalamic pituitary gonadal axis may fail to deposit bone, resulting in osteopenia and an increased lifetime risk of stress fractures. Low body weight and amenorrhea are the strongest predictors for low bone mineral density. This places the patient at an increased risk of fractures in their lifetime. The etiology is multifactorial, including reduced estrogen, progesterone, excess cortisol, and low levels of IGF-1. As bone loss may never recover completely, even once weight is restored, early diagnosis and treatment is paramount. Other complications include muscle wasting and weakness. all body systems are affected, including the hematological system, dermatological system, our head, eyes, ears, nose, and throat, and even our lungs can rarely be affected. The medical complications of eating disorders affect every system in the body and can take years to recover from. I briefly want to speak about atypical anorexia nervosa, where a young person is overweight and loses a dramatic amount of weight, but still remains within the healthy weight range. It is very important because medical risks can be under-recognized if they are normal BMI or normal weight for height. The loss of heart muscle and life-threatening arrhythmias do not require the occurrence of an exceptionally low weight. Therefore, they have a similar risk of sudden cardiac death due to prolonged QTC, bradycardia, and other arrhythmias. Refeeding syndrome is one of the most feared complications of refeeding. It is life-threatening, widespread organ dysfunction related to inadequate ATP production. In prolonged starvation, there is reduced blood glucose, resulting in catabolism of fat and protein stores and depletion of intracellular electrolytes, including phosphate. During refeeding, increased blood glucose stimulates insulin secretion. Therefore, phosphate moves into the cells to create more ATP for cellular metabolism. As phosphate concentrations are already low from prolonged nutrition, and now phosphate moves into cells, this can lead to insufficient amount in the bloodstream. Without adequate ATP, every system in the body is prone to failure. Traditional approaches to prevent refeeding syndrome assume that starting low with nutrition and advancing slowly is the safest way. However, there is increasing evidence that suggests higher calorie diets may have benefits without increasing the risk of refeeding syndrome. But despite recent advances in this, an optimal approach has yet to be established. Current general consensus recommends aiming for a weekly weight gain of 0.2 to 0.5 kilograms in outpatients, and regular monitoring and correcting electrolyte shifts if they occur. The role of the pediatrician is to complete a risk assessment on whether a patient is safe to do outpatient treatment for their eating disorder or whether a period of inpatient medical stabilization is required. They also then need to confirm the diagnosis of an eating disorder and exclude an alternative cause of the weight loss. Junior marzipan is an excellent guide to risk assessment that should be completed by the clinician. Medium to high-risk patients may require referral to local hospital for assessment and potential admission for acute management and initiation of nutritional support. Low-risk patients, according to the Junior Marzipan, can be accepted to eating disorder outpatient programs, but ongoing medical monitoring is recommended. Here is a risk assessment framework that has been adapted from Junior Marzipan, which stratifies the patient into red, high risk, amber, high concern, green, moderate risk, blue, low risk, and needs to be carefully reviewed. It does not replace a clinician's clinical judgment, however, is an aid to stratifying the risk of the patient. Important pieces to note are that vital signs should be measured both lying or sitting and then standing to look for orthostatic changes. Important when you're measuring a young person's weight and height to make sure that they remove their shoes, empty their pockets, and do a dry weight, so post-voiding urine, and first thing in the morning if possible. It is our responsibility to plot measurements on appropriate growth charts, calculate their weight for height or percentage median BMI, and if you have historical data, then it is important to calculate a percentage ideal body weight from their historical data on the growth curve. Baseline investigations include an SBC and biochemistry. If a young person is purging, it is worth looking at a VBG as well as a lipase or amylase. An ECG is essential in our risk assessment for bradycardia and prolonged QTC. The QTC needs to be calculated manually, as the machine calculations are not always accurate. It's also important to ask about a family history of prolonged QTC, and if it is abnormal on the ECG, this needs to be repeated when the young person is weight restored. Urinalysis is a very simple test that gives us a lot of information. Ketones are a byproduct of fat metabolism. Specific gravity can indicate dehydration and fluid intake and water loading. And blood can indicate menstruation or renal damage. It is essential to perform a detailed clinical history and thorough physical examination. This is in order to confirm the diagnosis of an eating disorder and exclude an alternative cause of weight loss. In the presenting complaint and history of presenting complaint, it's very important to get a timeline of the weight lost. What was their highest weight? What was their lowest weight? It's important to ask about their dietary restriction and how this has progressed, how there might have been changes in their eating attitudes and behaviors and meal socialization. It's important to assess their fluid intake and anything else they may be using to suppress their appetite or affect their weight. The amount and reasons for exercise is important to ask about, as well as any purging behaviors. It's important to ask about binging, body image, and to check whether the young person has any insight into their low weight, their fear of weight gain, or their medical instability. For females, it's essential to take a good menstrual history. Age of menarche, maternal age if the young person is premenarchal, and most importantly, when was their last normal menstrual period? And then we can see how long have they had a period of amenorrhea for. In previous medical and family history, it's important to check for any anxiety, depression, OCD, ASD, and even family history of eating disorders. In order to exclude alternative causes, we must ask about family history of inflammatory bowel disease, thyroid disease, rheumatological or autoimmune disease, and any genetic causes for short stature, for example. The pediatrician should take a developmentally appropriate psychosocial history. HEADS is a structured interview that aims to identify psychosocial risks for adolescents. Risk factors for eating disorder include stressors at home and at school, the young person being perfectionistic, then being involved in activities that place an emphasis on their weight or how their body looks, such as ice skating. Young people who may identify as LGBT are also at risk, as well as young people who have been bullied or isolated. Upon review of systems, what we're looking for here are symptoms of low weight, symptoms of orthostatic instability, and also symptoms indicating another disease. Physical examination, as I mentioned before, it is essential to take accurate measurements and plot them on the appropriate charts, to take orthostatic vital signs, and then complete a thorough exam from head to toe, looking for complications of the weight loss, as well as any signs or symptoms of an alternative diagnosis. For example, checking for axillary or inguinal hyperpigmentation indicating Addison's disease. Routine blood work is what has already been completed for the risk assessment. However, based on your history and exam, further blood work may be indicated. If you have suspicion of an alternative diagnosis, you need to do the appropriate tests. For example, if there was a strong family history of IBD, the young person also has diarrhea, very important to do inflammatory markers such as ESR and CRP, as well as a fecal calprotectin. In amenorrheic females, it's important to make sure that there is no alternative reason for the amenorrhea. Checking a beta HCG as well as a prolactin is very important. And then low levels of LH, FSH, and estradiol would be in keeping with amenorrhea related to anorexia or an eating disorder. I mentioned before that the ECG is essential in your risk assessment, and the QTC needs to be calculated manually, and there are different formulas and ways of doing this. The most common abnormalities we see are bradycardias, preventricular contractions, and arrhythmias. Under 15, an abnormal QTC is greater than 460 milliseconds, and over 15, it's greater than 450 in males and 460 in females. Where indicated, a DEXA needs to be completed to assess bone mineral density. Current international guidelines recommend this for females if they're amenorrheic greater than 6 months, and it should be repeated annually until menses resume. There is no definitive recommendation for when to do a DEXA for males. These other investigations are rarely required, but may need to be completed if you are suspecting an alternative cause for the weight loss. It is then the responsibility of the pediatrician to come up with their impression and plan. But this young person meets the diagnostic criteria for anorexia nervosa, for example. Medical complications currently include bradycardia and hypotension. Medical follow-up required includes weekly monitoring of vital signs. And what's key here is to state whether the patient is medically stable and suitable for outpatient monitoring, or whether they are unstable and require referral for medical stabilization and initiation of weight restoration in the inpatient setting. Thank you very much for listening to my talk today. I hope you found it informative, and I look forward to answering your questions at the end of the session.
Thank you very much, Dr. Walsh. It was indeed comprehensive and informative. And again, just to remind attendees that the anthropometric measurements that you described are often done by non-medics, but nonetheless, it's important to be clear about how to accurately collect them and to have availability of medical expertise for those cases where it is clinically indicated. I'm going to move on now to our third presentation and introduce to you Maria Keenan, who is a dietitian, again with expertise in eating disorders. And I think that's very important to remember, because not all dietitians provide the same sensible and evidence-based approach to managing this serious illness. And Maria has been working with us in our clinic coming from the west of Ireland on a regular basis. So we're very grateful for Maria's contribution. And Maria will tell us today about the role of the dietitian in our SIMPLE clinic. Thank you, Maria.
Hello and welcome. My name is Maria Keenan. I'm a senior pediatric dietitian in child and adolescent mental health service in Merlin Park in Galway. And I'm also involved in the SIMPLE study, which is a standardized inclusive medical psychiatry evaluation for eating disorders in Dublin, Rathgar. So thank you for joining me today. And I'm going to go through what I do on a day when I come to Simple Study. So we have family-based therapists that are working there weekly with young people, and we then, myself and the pediatrician, along with family-based therapists and the psychiatrist, come together to do a one-off consultation and provide a multidisciplinary approach to help with the progress. So from my side, I look at symptoms and activity levels. I assess the dietary intake and behaviour in food, what their weight currently is, where it's meant to go to, menses if it's appropriate depending on their age or their sex, social behaviour and self-monitoring, their requirements for weight restoration and implementation for plan at home. So looking at what their symptoms are, so bowels, like what's the frequency of? It can be up to a week or more, and is there laxative use or misuse? Often it's just down to pure and simple food and fluid restriction, and the body trying to recycle that waste product. And it's about letting the young person know that this is why, this is what's happening, and that, you know, taking in more food regularly will actually help regulate your bowels and stimulate the bowels to open. So the sleep, always disturbed unless you're on a medication already where you see them. It can be twice a night, it can be up to 4 or 5 times. And often young people are actually getting up and exercising because it's a false energy. And it's actually the body just looking for food, but it's just not knowing that, not being aware of that. Then I'm looking at their hair, their skin and their nails, and you know, labeling that as well, you know, thin hair, dry above skin, brittle nails, all down to nutritional inadequacies. And then the cold peripheries of your hands and your feet, you know, constantly having to put on layers and layers, and maybe having a hot water bottle when you're at home in the evenings. The mood, you're going to be irritable, your brain is starved, you're exhausted. We're thinking about food all the time, but we don't have it. And generally, we try to avoid social situations because sometimes it's easier because our concentration isn't fantastic, but also it's about a lot of the time it's social stuff, it's avoidance of food. Our energy levels, as I mentioned, are always depleted, and concentration can be very poor. Some people tend to fall asleep in class or have said that they're actually not able to recall what was said to them after 5 minutes. And then the menses, looking at whether it's primary amenorrhea, secondary amenorrhea, if it's secondary, for how long, and what are the implications of that. And again, just linking back that that's the body telling you, you know, that it doesn't have enough food to do these functions, and just, you know, labeling that. And then the activity levels, often they'll be at a stage where they're probably so severe in weight loss and energy deficits that they're now definitely not doing group anymore that they used to enjoy, but their performance has dropped. And, you know, they might be doing something solo, it'll be possibly long walks, and sometimes, you know, if they're not able for that, they'll start doing micro exercises, which is like standing for long periods of time, and when they're sitting down, shaking their legs, tapping their hands, and sometimes it'll be in bed, exercising, doing sit-ups, leg raises. So an awful lot of compulsions to exercise, just to keep the movement going. So it's just also about, you know, ensuring that we're telling our patients, no exercise. You know, rest is your new exercise. Lying on the couch is your new exercise. Your body needs to recover. We need to sleep. We need to reserve that energy. So that's a lot of it. Then we're looking at, okay, food isn't just about sustaining ourselves. It's not just about, okay, we have energy in, energy out, that's it. It's not. It's about a time with friends, being present with friends, being able to be present with friends, because we don't have to have this fear of food with us, you know. And often people will say, you know, maybe a year into the process, I can't believe that I'm actually enjoying a hot chocolate with friends. And before, they would have just avoided it or come really late or just sat with nothing, and it was so isolating. They say the whole time that all they're thinking about is wanting to be involved in that conversation, but actually just thinking about missing the food that they're missing. The other things are like social events, like parties, or, you know, even so much as eating in school, like, you know, going to your locker or walking around, you know, just to avoid that time so that you're not pierced with fear. And then looking at what clothes are we having at the moment. Are we buying smaller sizes? Are the sizes appropriate for our age? And are we really checking ourselves in the mirrors a lot? You know, are we weighing ourselves a lot? And if so, you know, let's get rid of the weighing scales, get rid of the mirrors. We need to stop that part of the brain from thinking that that's important. So it's about highlighting that to families and young people. Then I try and link the symptoms back to the recovery. So, you know, we have a window of opportunity. Most everything can be reversed, especially if it's got on time, and we can recover. And I suppose that's the message we need to tell people: recovery is possible. And the effects of starvation and restricting on nutrition, fertility, and neurobiology and bone health can all be reversed. And it's just about making sure that we get in at that key moment, making sure that we have that hope for the patient, knowing what a healthy weight looks like, knowing what growth rate looks like, knowing what, you know, what they were pre-morbidly. That mightn't be the case, we mightn't know that, but we know what the height is. We have growth charts that can tell us this is the trajectory for height, we go with that, you know, and making sure that the patient knows this is what's happening. And normalizing eating attitudes and eating behaviors. Food is our medicine, there is no bad food. We need to continue to eat with everybody, you know, make it social and make it easier for the patient. So weight gain, physiology, metabolism, all of that, we go from very flat to a really high metabolism. So we have to look at, you know, at the start, we'll start with our requirements, and it could take a bit more time for weight gain to happen because everybody's individual, but we have to look at what does the body need and not start really slow and drag it out, because we're, again, just restricting already restrictive eaters. And we have to look at challenging the food rules and the beliefs. You know, it might be, oh, carbohydrates are bad or gluten is bad. And we just need to make sure that we have the knowledge and we're providing the rationale to the young people that these are false statements and they're not evidence and they're not fact, they're actually just opinion. And then we look at the anthropometry, so we assess the weight and the height and the BMI and the percentage BMI. And we always do it in light clothing, chair scales, and the same as the family-based therapist would do it week on week. So we look at the weight history, weight loss, if we can quantify it, and then look at the ideal body weight. So it's all about that, where we assess and establish weight targets for recovery, and remembering that when we're setting them targets, if the child is age 12, to ensure that them targets are going to be moving up at age 13, age 14, age 15, because the normal trajectory for any adolescent, they'll all be going up. So it's about making sure that we're not restricting with our weight targets. And then analysing, okay, so we have the food intake, we know what's happening at home. What actually are we taking in iron-wise? Is that contributing to the fatigue and tiredness? Calcium intake, you know, ensuring that parents and families and the young person have all the information on how much calcium, how much iron that our body needs. And I do provide leaflets so that it's not just maybe they might feel that it's just my opinion, but actually I present them with the evidence of the day. Also look at B12 and folate, and the fluid intake. Are we overloading? Are we taking lots of caffeine for either a laxative effect or to diminish our appetites? And then looking at what are the deficits in each individual's dietary recall, or the deficiencies, and the history of the restricting and the cutting out food groups, and ensuring that we say there and then all foods go back in. There is no, unless there's an intolerance or an allergy from a long-standing history, or beliefs of vegetarianism, that the child has been brought up in that background, then all foods go in otherwise. So the assessment of the 24-hour recall, we also include the parents and the young person's likes or dislikes. So true dislikes, like what the young person wouldn't have eaten ever in their lives, like maybe oysters, or, you know, some people wouldn't have eaten mushrooms or celery. So something that's not in the last since the restriction started, but things that are true dislikes. And then looking at the meal times, like how long does it take to eat the meal? Are they spending an hour or over an hour in one meal running into the other? Are they eating alone? So it's more isolation. Is the young person involved in the cooking? And if they cook, do they actually eat the food that they cook? And then we're looking at, are they still calorie counting? Are they, you know, looking at labels? Are they increased fat and reduced protein and carbohydrates and dairy? And looking at all that, and looking at just distraction techniques, like are they breaking up and biting up the foods? Are they, you know, trying to throw the food in the bin? Feeding the food to the dog? You know, is it taking them like long periods of time before they'll start a meal? Do they avoid eating in front of others? So with the family, that they wait till everybody else is finished? Are they now irritated by other people eating in the noise? So it's about naming all of that and highlighting that that's anorectic behaviours, and that needs to be cut out, and that we need to progress on, because once we're exposed and we get through it, it gets easier. And then I work out the energy requirements for weight restoration and growth. And I suppose it's very individual. So it's definitely something that we need to look at, and that each family needs to know where they're going at. You know, most people will have met the energy needs for their young person that is coming to family-based therapists. But I suppose looking at the iron, calcium as well is another major factor, and protein levels. So we all aim for about 0.8 to 1 kg weight restoration a week, because we know that's the evidence. The more aggressive we can be, the better the outcome, and making sure that we're calculating those nutrition. Then a plan is devised, and it's not a strict rigid plan. It's more based around family meals and suggestions and snack suggestions. It can be 3 meals and 4 snacks a day, or 3 meals and 3 snacks a day, with the parent preparing all the food and the young person to be distracted and not involved. And this is to help, you know, decrease anxiety for the young person. The times are 30 minutes for meals, 15 minutes for snacks, and all meals and snacks supervised, and portion sizes like that, whether it's dad's portion, mom's portion, or an older brother or sister's portion, that's the portion they get. And be consistent with it, and be consistent with the times that the meals are at, and the routine of it, and discuss appetite regulation and bowel habits. So, you know, for stimulating the bowel, we should see within the first few weeks the bowel movements going from, you know, once a week to every 2 to 3 days, to then every second day, and then possibly to daily after that. And look at, is it a time to supplement with multivitamin and mineral, and is there anything else that we need in the background? So that would be discussed with the team. Consultation. And then the practical things, like, you know, I provide recommendations and suggested meal plans, and then ensure that, you know, preparation and planning for shopping is just the practicalities of it, that we have it done the week before, that we're planning out what we're going to have, and we stick with that. That if the young person sees us adding butter to potatoes, that we say, yeah, that's how it's done. That's, you know, we don't hide that fact. We ensure that we're not lying or deceiving the young person, but we're transparent, and we say that's how we make them, and that's just it, you know. And then looking at, you know, challenging those myths about foods and nutrition all the time, and ensuring that the young person gets back into eating a varied diet with challenges such as chocolate, such as crisps, such as a takeaway, and getting over those hurdles, and practicing at home what they might want to do with their friends. So if they think they want to go out for a hot chocolate, then we get that hot chocolate from that cafe and we take it home and we have it there. We might even invite a friend around to have it with us, and then we take the step. So it's always about thinking about what's going to be the next step for the patient, and the overarching goal, I suppose, of the whole FPT is to empower the patient and disempower the anorexia nervosa. And so at the end of the consultation, I go back, outline any concerns, request any bloods that are needed to be taken, and I share the plan with the rest of the team. We formulate a letter for the GP, and we return the care to the FPT patients. So I hope this is helpful. Thank you for listening, and if you have any questions, please let me know. Thank you.
Maria, thank you very much for that presentation. And the value of having a dietitian on board is that you're able to assess each child's individual areas of deficit, which not only might they be calorie deficit, and that obviously is dependent on how active a child is, and whether you have allowed them or encouraged them to go back to any type of sports, but also it allows you to see whether they might be deficient in certain food types, for example, calcium, and whether you need to reinforce the dietary sheet by paying attention to that. And I'm moving on to our last presentation. So we have presented to you up until now a kind of an innovative way of trying to make sure, despite constrained resources, that we're able to provide a medically safe outpatient treatment for young people with anorexia. And whether you link it to a generic CAMS or whether you link it to community general practitioner depends on your own work conditions. But now we're going to have a presentation from Hakan Oglutu from Turkey. And Hakan is going to think about, would it be possible to introduce the SIMPLE model to a different organization, different culture, and different system? So Hakan, over to you. Thank you.
Thank you so much, Professor Fiona McNicholas. And dear all, thank you for your attendance. I'm Dr. Hakan Oglutu, and I'm working as a consultant child and adolescent psychiatrist at Ankara City Hospital. Today, I'll present considerations of SIMPLE in Turkey. Let's start SIMPLE in short. Eating disorders impact young person's life negatively, especially mental and physical health. And the treatment choices are mostly family-based treatment or cognitive behavioral treatment. And if we apply these treatments earlier, we can get more positive results. For this reason, treatments and the detection of the eating disorders are so important. And now we can explain the SIMPLE project. It's a pilot project in Ireland to form referral and assessment of eating disorders. SIMPLE means standardized, inclusive medical evaluation and the psychiatric evaluation of eating disorders. It uses psychosocial model, and to form a standardized assessment for team members, IFME protocol works. IFME means a systemic approach, and it collects all of information about the onset, the maintenance, and the risk factors of eating disorders. I means individual factors. It contains eating disorders and other comorbidities. And F means family factors, like family stressors or family history of eating disorder or other psychopathologies. M means medical assessment, and E means environmental factors like academic or social pressures or academic cognitive vulnerabilities. Yeah, in SIMPLE, there is a multidisciplinary team, and this team is led by consultant child and adolescent psychiatrists, and the psychiatrist has to know very well eating disorders. He has to be an expert on this area, and an adolescent medicine pediatrician and a pediatric dietitian, and if we need other physicians can help us in this project. We form a multidisciplinary team with these physicians. And you can see the steps of the SIMPLE. There are 4 steps. The first one is to standardize clinical referrals. The second one is to accept all referrals from especially general practitioners. And the third one, to form an integrated psychiatric, medical, and dietetic evaluation. And the fourth one is to use standardized questionnaires in our clinics. About evaluation, in individual part, the clinical assessment is so important. For this reason, they prepared a template to search eating disorders. And additionally, eating disorder examination questionnaire, HONOSCA, to measure general health and social functioning, and child DAWA to detect other comorbidities are applied. And for other psychopathologies, RCAT, Revised Children and Adolescent Anxiety and Depression Scale, Quality of Life Scale, and Social Responsiveness Scale will be used. In family factors, family functioning, parenting stress, and family history of eating disorders are questioning, and they applied some questionnaires like caregiver burden, parental eating attitudes, or parental bonding, or parenting sense of competency scale, like related with parental stress. And in medical part, it contains the risk assessment, clinical history, physical evaluation, and the further investigations. And the last part is the environmental part, contains the cognitive batteries and activities, peer relationships, and hobbies like other clubs activities. Let's come to our country. Yeah, and in this country, in our Turkey, child and adolescent mental health services are typically based on outpatient unit in a hospital setting and run by a consultant child and adolescent psychiatrist. And there's no eating disorder specific service yet for child and adolescents. You can see our hospital, Ankara City Hospital, Child Hospital. This hospital is the biggest health complex of the Europe and the Turkey, and we are working in here. And the goal of the SYMPOL is to evaluate and follow up the treatment of eating disorder patients. And we try to set up an eating disorder service in our hospital. It's not official yet, but we try to work on it. And we used very similar method of SYMPOL in our clinic. And now I'll focus on the details of the SYMPOL in Turkey. We formed a multidisciplinary team here. Initial examination is done by a child psychiatrist, and consultations are completed by adolescent medicine, pediatrician, and dietitian. And if we needed, we consulted other branches. And this team is located in our hospital, and it allows us to assess like physical examinations, blood works, or ECGs. Yeah, you can see some pictures from our departments, child psychiatry, adolescent medicine, and dietitian parts. And you can see the steps of our eating disorder management. And first of all, we can accept all referrals, like self-referrals, school or general practitioner referrals, and internal referrals. And we started our assessment, treatment, and management in our outpatient unit. And if patient needs additional intensive treatment, they are accepted in our inpatient unit. You can see some pictures from our hospital. It's my room. And in our in outpatient units, we do initial evaluation, diagnosing, starting the treatment, supporting the family, administration of family-based treatment or CBT therapies, and we are continuing to follow up process. And once every 2 weeks, multidisciplinary team collects together, and we meet and we discuss the patients. And to form a standardization, we used some questionnaires, EDEQ, RCATs, and clinical impairment scales we used, and others depend on the child and presentation. And we use this Question is for the evaluation and the follow-up process. And at the end of therapies, with these scales, we want to continue with other therapy if patient wants another, if patient needs another therapy like anxiety treatment. And we do laboratory evaluation in adolescent medicine part. Yeah, complete blood count, serum electrolytes, especially potassium, calcium, chloride, and other electrolytes, and amylase and lipase, liver function tests, renal function tests, blood gas, gonadotropin, sex steroids, thyroid function tests, lipid profile, urine analysis, bone mineral density, and ECG, and we are applied these tests. Also, we do weekly physical examination. We weigh the child, we measure heart rate and blood pressure, sitting and lying. We record all of details, and if we see any problem, we will discuss in our MDT meetings. Otherwise, we cannot discuss these patients. You can see some pictures from our inpatient unit, from rooms. It's a social area for them. If cases needed to intensive treatment, we accept them to our inpatient unit. In this unit, we applied eating breakfast, lunch, and dinner together with our staff, and they give support to a patient's eating, and we also implement FBT and CBT and eating sessions with meals accompanied by parental supervision, and we can increase this parental control with these meetings. Also, we applied group meetings, morning meetings, other problem-solving skill trainings, social skills, and activities like cinema, theater, and non-intense physical activity like yoga. You can see our schedule of inpatient unit. It starts from 7 a.m. to 9 p.m. and it's full of activities. Yeah, as you see, Ankara City Hospital Eating Disorder Service is the only place where multidisciplinary eating disorder treatment is applied. And it's an informal service, and it's formed by individual efforts. And the number of FBT and CBT therapists are quite low, and opening specific treatment services for eating disorders are increasing FBT and CBT applications, and our patients will have the opportunity of evidence-based modalities. And as a conclusion, the simple method can be easily adapted to our country, and psychiatric and medical evaluation of eating disorders will start directly whenever the patient comes to our unit, and usage of standardized diagnostic assessments and questionnaires will increase the quality of healthcare, and MDT meetings with the leadership of child and adolescent psychiatrists will shape the patient's treatment. So we need a national clinical eating disorder program to form a model of eating disorder management. Thank you so much.
Hakan, thank you very much for, Hakan, please stay at the podium. Thank you. And thank you very much for the presentation. I might also ask my Irish group to stand at the podium as well if you would like to be visible to the audience. Hakan, maybe as you're there, I might start with you and ask you a little bit about, I know the eating disorder program is just commencing in Turkey. Could you say something about the numbers that you might have? Can you also say something about the proportion that would self-refer versus those that would come from a general practitioner? And whether you have any idea of the expected duration of treatment if they are admitted into your inpatient unit as opposed to outpatients?
Yeah. In Turkey, it's too easy to reach with a self-referral because we have an appointment system. Patients can call directly our 182 number, and they can easily get some appointment, and they can reach with the specialist. And it's too easy with them. And In Turkey, patients wants to see a specialist rather than general practitioner. For this reason, they can come directly to us easily.
Okay, thank you. We've a couple of moments for questions. I might ask a question of my colleague, Dr. Walsh. Orla, you had mentioned about the some young children who are presenting with normal BMIs, and oftentimes at referral that gives you a sense of security or confidence. Could you say something about some of the errors within that idea that you know, those with normal BMIs are not at risk of medical complications?
Yeah, absolutely. So it's really important. So atypical anorexia nervosa. So these young people pre-morbidly or overweight or above a healthy weight range, but they lose a dramatic amount of weight quite quickly. So they can lose up to 30% of their weight, and they stay within a healthy weight range. But this dramatic weight loss can have significant physiological consequences. So on their cardiovascular system. So they have the same amount of risk of arrhythmia and QTc prolongation. And if you put that together with any electrolyte abnormalities, that's really quite dangerous. So when you see a young person, their weight history timeline is very important. The rate at which they are losing weight is also very important. And where their weight is relative to what they used to be, to plot that and look at that. With every child, a good assessment starts with good vital signs. So orthostatic heart rate, blood pressure measurement, and an ECG is vital for all patients who we're assessing, whether they're in a healthy weight range or not, in order to assess their medical stability. And it is under-recognized. A lot of pediatricians, psychiatrists alike would say, oh, she's in a healthy weight range, she's safe for her. A lot of people say, sure, she can't have anorexia nervosa, she's not underweight. Yes. But they can, it's no longer, it's a low weight relative to what's healthy for them.
Yes, and Orla, by way of trying to help the young person with the target healthy weight going forward, I mean, obviously we don't want children to fear that they're going to become overweight, particularly if there had been a recent increase in adiposity. But how important is return of menses in giving you some kind of security that even if they've only got to, let's say, 120% IBW, and pre-morbidly they might have been 135, but menses periods have come back, how helpful is that as a kind of an interim measure at least?
Yeah, so I am guided by vital signs and return of menses, and it's a lot about education and support for that young person and their parents to understand that. I explain that our bodies are very clever. They maintain us, throughout our childhood, throughout our adolescence. When we are well, we could say your period or your menses is a vital sign. When we are well and healthy, we have our regular period. If we don't have that, then we know that something is off. And what we know for you is that you have been restricting, you've been exercising. So we need to allow your body to recover, and your body will tell us when it has recovered by having your menstruation return.
Thank you. Maria, I might ask a question of you. Increasingly, adolescents now are beginning to be vegetarian and indeed vegan. How do you manage that in your clinical role as a dietitian? And Maria, if you wouldn't mind taking your mask off for
sure.
Thank you.
So it's a difficult one, isn't it? But I suppose it's again looking at the history, looking at when did it start? Did it predate the eating disorder? Is it that they're reared vegetarian? And very few people are reared vegan or vegetarian. So about 1% of the whole population are vegetarian, but about 13% that come to CAMS with an eating disorder are vegetarian. So, I suppose, for instance, I had a patient recently who was an inpatient, and for 6 whole weeks he told me he was vegetarian, but he was taking gravy, and he was taking, when he went into the hospital, he had been vegan. So when he came to us, he started eating the dairy again, and 6 weeks in, after explaining to the parents of the evidence and what he'd been doing, a vegetarian wouldn't take gravy, it's made with beef stock. So the next day, after we had lengthy discussions with family, he put it back in.
But it's really about making sure that we have the evidence and the rationale for why we don't support it, I suppose. And we would support somebody who's reared as a vegetarian. So that's absolutely fine. But it's just about making sure that we give them the knowledge as to, you know, what we're going to be deficient in and the amount of food that they're going to have. Because they already have to have about 1.5 times the size of a regular portion if they didn't starve their bodies. So now they're going to have nearly twice the amount that the person who's not being a vegetarian.
And if we think about some cases like RFID or some children with unique dietary, maybe sensitivities or allergies, what is the role, you know, in a kind of, or is there any concern if somebody needs to regularly enhance their daily dietary intake with something like a 40-sip or a higher calorie drink?
Yeah, I suppose that can happen, but by and large, you try and go with food first. So I suppose it's like taking a supplement instead of having, you know, say for iron, taking a supplement when they're deficient, but when it comes back to normal, you know, we should be getting the 2 portions of meat in a week. It's about looking at, okay, so we have a drink to take, but it's not normal. And actually, by reintroducing the food slowly and getting the fear of the food, so taking very small bits at a time, if it's to do with ARFID, and swallowing it and being able to desensitize the mouth and train the brain that it's a safe food. And I think it's about like explaining that, not rushing it too much, but making sure that we have the energy in the other foods because we can get it that way. And we can supplement with your multivitamins, but it's about making sure that we're not having that a long-standing thing, because then actually we haven't normalized the eating pattern and we haven't normalized any behaviors.
Thank you. Thank you. Una, last but not least, I'm interested in our kind of multidisciplinary component. The one thing we haven't included yet is input from parents, although that happens very much at individual level. And we've certainly spoken in our clinic here in Lucina about running parent groups to supplement the FBT. What's your sense in terms of the need for additional parent-only support, and then how might we be able to bring parents into the development of clinical services in a helpful way and consistent way, I guess?
Yeah, I suppose certainly we have seen like so many cases where the parents certainly feel overwhelmed and feel like they're the only people in the world being asked to do this and being asked to refeed their child. And you know, we've seen through Lucina in other parenting groups that actually by bringing parents together, they feel a sense of community and support from each other. Ideally, like we did some training with Jill Todd, and ideally we'd love to bring in a parenting group and over time bring parents in to help us run that group as well and get their perspective on the recovery and how they, I suppose, felt at the start of this process and then, you know, how that feelings in themselves as parents and their own confidence grew as the child recovered and as they moved forward. So at the moment, we're limited. We are just getting the parents' feedback in their own individual sessions. We do use our colleagues in Bodywise, who run a fantastic program, the Pillar program, and we would recommend all of our parents that attend us to go to that program, and we get amazing feedback that really helps to support them. So yes, I think down the line, it would be amazing if we can start running a similar program here, including parents in the running of that program and in the setup of that program. I suppose to create that community and to feel that peer support, that they're not alone in this process.
Yeah, thank you, Una. And maybe just to finish by asking Hakan, in Turkey, is there, like Bodywise is our eating disorder support organization, which is an excellent resource for parents. And indeed, we're trying to work more collaboratively with Bodywise within clinical services, both pediatric and community. Is there such a service in Turkey? And are there advocates among parents and families for eating disorder services?
Yeah, unfortunately, we haven't any service like that yet. But maybe parents collect together and maybe they form a union like that. But we have to promote them. And additionally, multi-family therapy maybe if we apply, they can collect together and they can easily to form a treatment for them additionally. But yeah, we have to need them, especially the union of a parents of a child with eating disorders, because they have high care burden, as we did our research with you, and it's so important for us.
I can definitely see that the value of having parents involved in the delivery, the planning, and the evaluation of services, indeed along with the young person, is very, very key. One of the issues is, you know, when you have staff in an organization, they're employed and they're permanent, and so you can develop things with them. One would hope that there would be a way where parental involvement may be able to be, obviously it may not be permanent because parents move on with their own lives, and, you know, as Una said in the beginning, it's very much recovery. You know, the young child and adolescent does get over their eating illness, and sometimes they don't want to revisit it. But it is the tension around having a consistent group that align with clinical understanding, because there's so many different approaches to managing eating disorders, and very many different approaches in the clinical and dietetic area as well. In the interest of time, we're going to have to close the session. I would just like to remind everybody that at your time, it is happening at 5 o'clock. We're having another eating disorder symposium, and we're having Bodywise, and we're also looking at the carer's perspective. And we're looking at some of the issues with regard to stigma and attitudinal issues that act as barriers to developing effective services. So we hope some of you might be interested in coming back to that. The other thing is we're having on Saturday, we're having a very practical clinical session on Saturday, I think about 10:45 your time, on looking at some of those parameters, cardiovascular and laboratory parameters, in terms of how, as a primary care clinician, you might be able to be more informed about when you need to seek the expertise of somebody like Dr. Walsh or Dr. Richardson, who'll be joining me on Saturday. And lastly, to add that we're very happy to share all the material that we have developed for our Simple Clinic. It's a work in progress, and we're delighted that Hakan is taking the lead in working with the group in Turkey. But if anybody else would like to get in contact with us, maybe let Hakan know and we can collaborate future. Thank you very much, and thank you most sincerely to our speakers this morning.
Professor, can we ask questions from the physical attendees?
Yes?
Yeah, do you have any questions from here? Yeah, Professor.
Thank you a lot for your excellent and brief presentation. I have a question to Dr. Lehmann. What do you think about the talking to the patient regarding the risk, medical risk and mortality risk of this disorder?
So Una, for you, how might you talk to the patient and inform them about the serious medical risks of their eating disorder?
Yeah.
Thank you.
Thanks for your question. I suppose along with our FBT model, in our very, very first session of FBT, we laid the grave scene, and we very much speak about the risks. We speak about death. We speak about osteoporosis. We speak about fertility levels. And, you know, it's really important, I suppose, for both the young person, the parents, and their family members to hear all of that, so that they understand why we're taking such a serious approach to this, why we're going to be monitoring it so clearly. So for us, we certainly want to let the family and the parents know those risks, but also to reassure them that we are going to monitor as the professionals, that we're going to keep an eye on that at any point, if we feel that this young person is too medically unstable for outpatient treatment, that we will refer them into a hospital, but that our aim in FBT is to try and manage those complications in the community and to try and keep these young people at home and hold that medical risk where safe to do so. So certainly we would talk quite openly about those risks with the parents, the young person, and the siblings in the room as well, so that there is no, I suppose, misunderstanding
and that everybody is on board and understands why we are taking this so seriously.
And the other thing to add to that is that we revisit it, because sometimes in the beginning, the young person, the egosyntonic nature of the eating disorder, they don't want to give it up. And it doesn't matter how much you tell them about the medical risk, they're not in a position to hear it. So we layer it on a regular basis and we revisit it. And we hope as they improve in weight restoration that we're able to actually identify motivational factors that allow them to start making greater improvement.
Thank you. We are a very small group in this meeting room, but there are many listening to you via online. Thank you a lot.
Thank you. I cannot see the audience to know if there are any other questions. Or Hakan, do you think we have addressed all the issues?
Do you have any questions additionally? Okay, Professor Fiona McNicholas, we haven't any yet. Yeah, you can close it.
Okay, so thank you very much, and we look forward maybe to seeing some of you later. Take care.